Good afternoon, everyone. No countdown timer today, purely because we still haven't got the new intro sequence and stuff. That's just pending, and I just do not want to blare out that loud music that you always heckle me on. I'm Jack Chew. This is Chewing It Over, 12:30 till 1 o'clock. Now, Mondays and Fridays, discussing whatever is topical in my world, which is often MSK practice, rehab, pain, and all things associated to healthcare and where that intersects with culture. I'm really pleased to have a guest on that's been long awaited. I had to cancel on him last minute when I got sick at some point, I think in December, it might even have been November, but absolutely cracking thinker and someone that I've been really looking forward to having a chat to about this topic, but he's also a font of knowledge in many other areas as well. So we'll mention no doubt at the end, but you need to go and look out for his stuff, especially the way in which you can signpost patients to that on the wellness puzzle. So do check that out on YouTube, but I'm sure we'll get to that and his ventures there, which is great. But on this, one of the things that we're often asked as Physio Matters, really more than this show, but it's like, where are the distinctions and where are the overlaps between different disciplines and sub-disciplines within MSK practice? And so it's really good to be able to get stuck into that today with Mahin, and hopefully in the click of a couple of buttons, I can strip back my little border there and bring you Mahin. Mahin, can you hear me, mate?
Yeah, I can hear you good. And I think it's already a good start, to be honest, Jack, because I'm not had to listen to that intro tune.
Absolutely. You didn't have to cover your ears all of a sudden. No, that's good. Well, we're working on that, as you know. But yeah, it makes it. I'm glad we've started well then, pal. Just for those that don't know you, just introduce yourself if you could for the listeners before we get stuck into the topic.
Yeah, sure. So I work as an APP in pain management with Occ Health, working in Wolverhampton, and been working in pain for about 3 years now. And before that, I was working in MSK. So yeah, I made the move over to pain. I've been working fully in pain for the last kind of 2 years, and that's kind of where my career's gone. And then outside of that, I think you mentioned in the introduction that I started a YouTube channel and a blog last year called The Wellness Puzzle, which just really talks about the importance of our lifestyle on our own health, but also hopefully to reach a wider audience with the messages around pain management and things like that. So yeah, that's a little bit about me.
No, brilliant. No, thanks a lot, and thanks again for coming on the show. This topic is one that is there's an argument in a way that suggests that it doesn't matter. Well, why do these things? What's it? It's all the same, etc. But it's not. It's not when it comes to, say, funding or commissioning, and it's not necessarily when some people love it and some people don't, and therefore that's got a really relevant staffing related thing as well. But when we're creating resources or trying to help people, then it's often useful to admit to some of the distinctions, as well as then helping them to understand how they could become overlaps, or where they might be thinking that things are more separate than they should be. So I want to just throw it over to you, if I can, to start us off, as to just get your take on this matter, this subject more broadly, as to where you feel the distinctions or overlaps are with it.
Yeah, so I think to answer the question that you've got on the screen at the moment, so is pain care distinct from MSK? I'd probably say in reality at the moment it is, but ideally it perhaps shouldn't be.
Right. Okay.
Probably get into that a little bit more. So I think this will vary from services as well. So some services like our own will have an MSK arm to the service, and they might have a pain management arm to the service. So I work in primary care setting, and within that alone, I think might be very different to another service, which is MSK only, and then they might have a secondary care kind of pain service that's not directly attached to theirs. And there's probably some differences within that. But I think you've got a couple of big things that make they're probably quite distinct. Is, I think, time. So amount of time that we have in pain services compared to MSK services. But also I think there's a feeling that we might be doing something a little bit weird and wonderful in pain services when perhaps actually in reality we're not.
Okay.
And I think as well, then when we're coming back to kind of ideally, we'd hope that there was less distinction. And I think that's what we will come on to later on in the conversation. But if we're honest about it, the large proportion of the MSK caseload is persistent pain as well for a lot of people. So people see a lot of chronic pain patients within their MSK caseload. So perhaps maybe it shouldn't be as different as it might be at the moment. And that's probably my answer to the question.
Yeah, no, that's a fair point. Yeah, what is now and what should we aspire for it to be? I think that's a fair distinction already. What I wonder is, when it comes to pain care, chronic pain services, etc., depending on how they're commissioned, it's like even the terminology doesn't help, because managing someone's chronic low back pain and managing someone who has chronic low back pain secondary to cancer, we know that those are relevant distinctions anyway as categories, but also the phenomena of the pain that they're experiencing might not be, to them, that's not that relevant a distinction, right? That these are conditions of which they're suffering from. But the management of it would be quite different in a way, because the way in which someone will be seeking, one of those people, granted you would never, few would opt for, a back pain secondary to cancer, but they have an answer, they have an explanation, at least one that has been provided to them, sometimes clumsily, but there's just this really metabolically active tumor that is then, and granted, that's a very simplistic definition, but it's one that they could comprehend and therefore are more likely to be compliant with, say, medication or strategies of which they needed to just do to get through that. And the sort of fighting analogies and militaristic analogies that come from fighting cancer, of course, can be problems, but they kind of pursue that. And therefore, pain management for that world, as is distinct from MSK chronic pathology. But from what I understand, some services end up almost having, all of that in amongst it. So, how do you reflect on the, say, cause, or what are the causally relevant pieces of information as to what is underlying someone's pain condition, and is that a distinction that's worth making?
Yeah, and I think it's a good point that you mentioned around the terminology as well, because for those group of patients, let's say it's cancer-related pain, the word pain management is still used, isn't it? And even if we're looking at kind of the medication management of those patients that may be more kind of opioid based and things like that, something we're moving away from for kind of non-cancer related chronic. And I think that's probably where the conversation today will probably be. Yeah, probably it's wise that we mention that we're talking about that kind of non-cancer related chronic pain. But I think historically, when we've used the word pain management, the approaches that we've used even for non-cancer related chronic pain has been similar to those that we've used in those more kind of serious conditions in terms of the medication and so on. And I think actually when we're talking about kind of MSK and pain care, the pain management that we're talking about today, so the kind of non-cancer related pain, lies closer to the MSK pain management than it probably does with these other forms of pain management that are there for completely different things. So I don't think the terminology helps with that. And there's been discussions ongoing for a long time whether even pain management is the right word, because actually, are we even trying to manage someone's pain who are coming to see us? And can we have a direct influence over that? And is it helpful to suggest that we can a lot of the time?
Yeah, it could be. Yeah, people have worried about it being sort of almost false advertising, hasn't it? When it's been something that then understanding and pursuit of functional improvement is usually where it's sort of directed, and education. What do you see as being the distinctions in timeframes? Because often it's a bit of, there's these cliched anything beyond 3 months, and these things usually were just taking a mean average of sort of tissue healing, or when the majority of tissue healing would be seen as being sufficient to have recovered, that then anything beyond that wouldn't be related. But we know that different tissues that take longer than that, but also that people can have presentations that would potentially suit your style of care far sooner than, say, 3 months, and that fundamentally those sort of time frame distinctions are a bit tired. But what do you feel, or what even policies do you guys have that make that qualifying versus disqualifying for services?
Yeah, I think that's a really grey area, isn't it? So in the service that we work in, if we kind of put the definition of chronic pain at 3 months, I think we'll probably have very little people in our MSK on our MSK and more in pain management, because by the time a lot of people have been through, living with that pain for maybe a month or two, going to see the GP and then coming to our MSK service, they've reached that 3 month mark anyway. So yeah, I think the definition around that 3 months is more there so that we can define it in a way. But you're right, there's so many different factors that go into it, and a lot of people show signs of potentially kind of more of a persistent pain condition earlier on in that time. Some people, actually might go a few months and actually they come out of it after 5-6 months, and that 3 months is really kind of irrelevant. But I think the thing that's tricky is knowing when then to refer. So if you're lucky enough to have pain management services connected to your MSK services like we do, it's knowing when is that person then appropriate for pain management. And I think this is where the kind of the distinctions come in between the pain and the MSK, and I think it really goes down to how much support that person needs. So are they not I don't want to use the word kind of progressing, because I don't know if that's the right word, but are they not kind of going through the MSK journey, or are they not kind of responding to physio in the right way that we'd expect them to? Or are we actually finding that there's a bit of a mismatch between what the patient really wants to get out of this and actually what they're getting from an MSK point? And do they need that more time then in a pain service, and perhaps other things like pain management programs that can be helpful that look at the wider kind of aspects of this? And I think it really is if the pain is there and it's obviously impacting function, but then is the pain impacting other things? So is it starting to impact kind of their mood? Is it starting to impact their relationships? Is it starting to kind of have that wider impact, and kind of call it the ripple effect? So if you're throwing that a stone into a pond and that stone's being pain, those ripple effects are the secondary effects of that, and it's how wide those ripple effects go, which is probably what determines whether that person's going to come over into a pain service from the MSK service. And I don't think that's because because of the skill of the clinician all the time within the MSK service, because I think there's some really good skilled clinicians who manage persistent pain really well. But I think sometimes it's the timing element and the support element and having that wider team. So it might involve psychologists, a bit of kind of meds optimization stuff as well.
I definitely don't want to be putting any words in your mouth, so if you disagree with me on this, then do let me know. But I feel like there is still a lot of work to be done for upskilling MSK, so classic MSK services in the comprehension of persistent pain, as well as then trying to demedicalize or try not to latch on to narrow biomechanical variables and implying causation to them, etc. Often talked about that a lot on this show. But it's just that then I do feel that to some degree, we both clearly want to bridge the gap. It shouldn't be as distinct as it is between those things. But one of the things that needs to be met as well is that whilst that's happening in MSK, I think pain services and that as a discipline is such that then has somewhat left it behind, right? That gap has become larger in part because one isn't moving quickly enough, but the other one has then become so distinct from, say, it's any implication of, say, structural contributions or any implication of biomechanical contributions or people feeling like they can be met. And obviously, be unfair to say that therefore that's not patient-centered and that they're not getting great results. It's just more that then it feels like those two languages are not being spoken, and that those distinctions between classic MSK services and pain services, the aspiration to bridge that gap and for us to be speaking as one language, that sometimes I fear those two forces really, and that latter one is seldom talked about. I just wondered your thoughts on mine, but also then if you do have any concerns in that direction, how we can mitigate them so that it doesn't seem that it's a totally foreign language to be working in persistent pain.
Yeah, I think you're right. I think there has become a bit of a gap, and I think almost because there isn't as much crossover between two services a lot of the time, even when you're working next door to each other. It's something we see in our service. But actually, we work closely with each other, but there's still that gap, and it's something we're actually trying to work on at the moment, and we're developing a bit of a kind of a pain experience role for someone within MSK to come and spend some time within the pain service to kind of upskill in that area and hopefully reduce that gap a little bit. But I think the way that we've got to have a look at this, and this goes for anyone whether working in MSK or pain. So if you look at people at one end of the pain management spectrum who might be still more interventional with their strategies, they might be more of that kind of more medication focused, and then we're looking at people on MSK. It doesn't matter where you sit within that range, but I think the thing that we've got to remember is what is our role here as physiotherapists. So speaking about kind of from a physio point, because obviously Physio Matters podcast, so most of the listeners here being physios, is what's our role as a physiotherapist? And for me, I think our role as physios has always been for the rehab aspect, and rehab is getting that person back to where they want to be, or being able to engage in activities that they want to engage in. So that's the same. So that's the same for whether it's MSK or pain.
Sure.
And I think one thing that we potentially need to have a look at a little bit more is the wider aspect. So we are very exercise focused within physio, which is great in the way it should be, but actually, do we need to focus a little bit more on the other stuff around kind of the behavior change, the lifestyle change to feed in with that? Exercise is not necessarily rehab if it isn't moving that person towards their goals, improving their function, getting them back to their activities. And exercise can be a standalone thing that somebody does a couple of times a day without moving them towards where they want to go. So rehab is wider than exercise, and to be involved, to be included within rehab is those are the lifestyle things, and potentially looking at people's sleep, looking at people's diet, looking at how stress impacts the way that they're functioning and so on. So I think the luxury that we have in pain management is we have the time to maybe discuss these things, but we also have things like pain management programs where we go into more depth on these areas. And I think it's something that MSK would like to do more of. And I think we should probably be doing more of it, but it's just how we use that time within the shorter kind of consultation times that we have within MSK.
Yeah, I think it's a really good point, and people do worry about the fact that it's all well and good, and I'd love to be able to do that, but I haven't got the time to, or can't prioritize that. I think that we'll definitely come back to that, because I know you've got some great tips and tricks for those that are shorter on time as to where they could prioritize things. Just before we get stuck into some of those more wellness aspects, which the holistic care that needs to surround people, that I think are the perfect area where there should be more overlap, right? These are complex humans in complex systems, and where exactly they are, there are some similarities we can focus on. Before I do that, I just want to ask the live audience that have tuned in to ask you a direct question, really, as to what do you feel the distinctions and overlaps are between pain services and MSK services, your reflections on whether that matters or not, whether you think that's done well. We spoke at the beginning of the show, you might not have tuned in for that first few minutes, but we were talking about the fact that we think there probably are more distinctions that they should be, but we should aspire for them to be less. Is that your take as well? So do get involved in the conversation. Love to put your questions to Mahin, or to get your reflections more generally. I know what you like when we've got a new guest on. You're often a bit cautious. It's last few minutes. You then come in with your questions and comments. So do get them in now if you would. But yeah, Mahin, let's get stuck into then the more holistic aspects then, because you've got that time within pain management programs, etc., to educate. And also, there's one of the few upsides in a way to not personalizing care to the nth degree, is that people can sometimes be reassured at some of the generic factors of the fact that it's not only me, and that starts to create community, etc., that you can do within more group settings. What are that is an area, I would say, and I think we've spoken off air about this, that he's done very well in pain services relative to MSK, which can sometimes be a little more blinkered. Like, it's easier to get a bit wider picture when things haven't worked before, and sometimes people going through those processes of things not having worked. The only upside of that is the fact that then it can give, clearly it's a little more complex than this, and that patients are often more accepting of it. So I just wondered your general thoughts as to. And also, if I can invite, how you ended up in the sort of public health space, especially with messaging, because you clearly didn't see these things as being distinct. You're an MSK and rehab physio that then went into pain, and then it didn't see. It's not as if you overtly wore a different hat to then go into the sort of public health and holistic messaging space. So, just your reflections.
Yeah, I think when I came over into pain, I probably wasn't as aware of that overall. The importance of looking at overall kind of lifestyle on pain. So it happened because of a couple of reasons, and these things happen similar together. So I had a own personal experience where I suffered from an infection and had kind of fatigue after it that lasted for, I think, about 9 months, which made me look at my own kind of lifestyle and making changes, and actually how much that helped me on a personal level. But also then, when I started working in pain and we started going through this stuff in the pain management programs, all this stuff about sleep and other things, that really helped me from the personal aspect that I was looking for. But I started to see what the impact it had on patients as well. And actually, how everything is so linked. We know that things are linked. So actually, by even just focusing on one area, we might focus on sleep. It actually made people more active the next day because they had more energy and they were more willing to kind of go out and do things, and that improved mood. And then their mood improved their sleep, and then things had a bit of a knock-on effect. So I think starting off in the rehab aspect was really good, and I think, you know, and that's why we become physios, right? We become physios to rehab people better and get them back to the things they want to do. And it becomes a bit more of a challenge when you work in pain, because you don't see the same results as you would in MSK. So there's other ways of having a look at it. And I think recovery looks different for everyone as well, doesn't it? So you might have someone with more presentation with an MSK who wants to get back to their sport or get back to work, and you might see quicker progressions with them. In pain, you don't always see those quick progressions, and it's knowing what recovery looks like for that individual and what they want to get out of it, which is really important. And that's the same as MSK in pain. It always comes down to that question, doesn't it? You know, what do you want to get out of your time with us? You know, why are you in front of me as a physio? What can I do to help you? And that's the same question in MSK and in pain.
And that's the thing, is that it depends on what the people's biggest fish to fry is. That, you know, sometimes zoning in on sleep, fatigue management, nutrition. You've no idea as to whether or not that might be a priority for them, or whether those pennies are going to drop. In other people, those things aren't so much of a priority. And then when it comes to the rehab, I remember speaking to neuro colleagues who often they'd said that they were jealous of MSK sometimes with regards to the speed in which they can get things going, but not as jealous about the variety, especially diagnostically. They felt that was something that was quite daunting about our work relative to them seeing stroke patients or Parkinson's disease or MS, etc. But even within that discipline, I find it interesting because I think pain has ended up situated somewhere between those two things in MSK and neuro, because it's needed to become much more understanding of the neurological impact, shall we say, or that pain, some argue, a neurological phenomena in most ways. So that it's had to upskill, but then it's sort of situated where, compared to say MS care, where you might be trying to, you know, stop decline, in pain services you still would be hoping to functionally aspire someone to be more capable than they otherwise were. So it's interesting that rehab is the great unifier. I've often talked about that. And you're right, you would assume that people get into physio to get into that. But I heard from my friend Tom Jessen, who broke my heart the other day, saying that he doesn't particularly like rehab, and that's not what he's that into, which hurt me. A couple of answers to my question for those of you tuning in live. Thank you to Liz, who said there shouldn't be a distinction, not in the way there is now. If we didn't have time, maybe it's because the model of care the model of care needs an overhaul. So yeah, Liz, of course, my fellow reformer, you know, music to my ears. Talita said this, which is interesting. I feel like I want to follow up with this, Talita, if you're still listening. Having been solely in private practice physio since 2008, our local NHS pain management services appear to be a bit of an enigma, an apparition. Is that an access thing, Talita? Is that because you feel like you don't know how to, or they've not reached out, or are you seeing some of the consequences of that service not being up to scratch? Because that's a shame. I suppose that's the first cross-sector question, Mahin. I just wondered your thoughts on, do you feel that your services have good links with the community more widely and other sectors?
Yeah, so I completely hear what Talita was saying in that, because I think sometimes this is not even a question of MSK to pain. A lot of the time, this is sometimes a question between primary care and secondary care, and that the relationship and the conversations you're having. It is, from my experience, that's not always been easy to have those open discussions all the time. So that again is another barrier to this, isn't it? If you aren't able to have those discussions with your secondary care provider or whoever it might be, I think it's easier to those links within the community when everyone's, you know, if people are working all in primary care and having links and signposting links elsewhere. But it can be a bit of a challenge. Sometimes a way of approaching it is, and I got this a bit of advice, was going with the approach of trying to learn what they do and knowing what patients they see, so that you can make sure your referrals are better. But it can be a real challenge sometimes. Having that. So I completely agree what Talita's saying there.
Yeah, those communication channels cross services. It's definitely some work to be done there, and we've spoken about that in other areas on this show. Dave McClellan said, I think MSK and pain management are beautifully intertwined. I imagine he's meaning there, interlined. we try in our practice not to differentiate the two, but to take the overview that rehab is the healer. Great discussion. So it sounds like Dave's agreeing in the main, but I think that what is interesting is that notion that we know it could be better, but we should all be aspiring for it to be more overlapping. I think there is, though, to give credence to an argument that keeping some of these things distinct, one of the reasons that people try to do that, or one of the reasons services are commissioned separately, is the idea that then you can create specialism within that and a specialized staff base. One of the obvious upsides of that is that the specialist staff base would then be more efficient at treating pattern recognition, etc. But one of the fears and concerns that some people have is that then that those distinctions become too crisp, and that people end up falling across boundaries, or that people, in a pain service, they might still have an MSK. They can still sprain their ankle, or they still develop a fracture, etc. And sometimes it's those distinctions have been made too crisp. What are your thoughts on that then, from regards to a staffing point of view? Do we get that bit right?
Yeah, it's difficult again, isn't it? Because it's not that every service has a pain management service to turn to that's right next door. So I think you still need the speciality there, because I think there is a lot of complexity in pain as well, and I think you need to have those other kind of the wider MDT around that. But I think for career progression, it's a good thing as well. It's good to be able to aspire to a different level, to an APP position if you're a physio that works in pain management. So I think it's really important to have that. And again, but the only thing is how do you reduce that gap between when that person's ready to step up? How do they step up? Because if they've gained their time within MSK, but then they want to make the leap into pain management, but they're unsure whether they're actually going to enjoy that role or not. A lot of the time there aren't, there aren't kind of junior physio or even senior physio positions within pain management, which can make that a challenge, because the only experience this person would have was chronic pain within MSK, not within a pain management service. So is there better ways that we can actually expose people to pain management, so they can make a decision whether they wanted to come there and progress their career to that a little bit sooner?
Yeah, brilliant. No, that sounds smart. I mean, we've mentioned a few times over the course of this half hour about the time differential between pain services and MSK services, and that's often what people will say. They'll throw their hands up and say, "I'd love to get stuck into this if only I had the time." What are your top tips then for those to get most bang for their buck if they only have a few additional minutes where they could, I suppose, first do no wrong, say no wrong, and those sorts of things, really, is to not make the mistakes of scarring people. But when it comes to actually making a positive brief intervention, what would your top tips be?
Yeah, so I wanted to raise this earlier, because I think this is the elephant in the room when we talk about the distinctions between pain and MSK, and I didn't want to just kind of glide over this without talking about it. So I think but the biggest tip, I think, if you're in an FCP clinic or you're in an MSK clinic and you have less time than we do in pain, my actual biggest tip is to try and do less in that first consultation, because one thing we have to really be aware of is that patient has probably been to a number of physios before in the past, and how are you going to be different in this consultation for that person, so that they don't go around in that same cycle that they've been in. And I think as physios, because we want to help, naturally, as healthcare professionals, we want to help that person in front of us. We try to do loads within that session. Now, the first thing is always, after you've screened for kind of serious pathologies and all that kind of stuff, and making sure that person's the right person for you, you're the right person for that person. There's three main areas that I think we need to try and cover in the first consultation. The first one's kind of understanding the patient's journey and validating, their story, allowing them the opportunity to be heard. We have more time even in MSK than GPs have, so we've got a really good opportunity to do that. And it gives a really good insight into that, where that patient is on their journey of acceptance as well, and also, the discussions that might come up in the future. So just allowing them to kind of tell their story, and also what their expectations might be of their time within our service. Right. So what are they here for? Because you can very quickly address those then and explain what the role of your service is. The second thing is also then to identify what's important for that patient. So what are their meaningful activities that they want to get back to? What are they really struggling with? So that's the second thing. And then the last thing is agreeing a management plan. So if you're an FCP clinic, that might be a referral onwards, or signposting, or if you're an MSK, you know, what's the plan for the next appointment? And I think that's it. I honestly wouldn't try to do loads more than that, because the one thing we've got to remember as well, so in that 20 to 30 minute appointment, you aren't going to change the 10 years worth of pain that person's had. And what we can sometimes do, and this is a kind of a do not, which I'd say is, we go through the consultation, we do all of that other stuff right, we listen to the patient story, and then we rush to give a sheet of exercises out at the end of it. And that can kind of undo the work that we've just done within the consultation. It kind of invalidates the story in a way.
Sure.
So that's the one thing. And the other thing I'd say that don't do is, once you've gone through and you've ruled out the more serious stuff, or you screened for the more serious stuff, is moving away from that diagnostic assessment approach to more of a conversational assessment approach. And you just kind of just as if you were meeting someone, a friend or something like that, and having an open discussion with them about what they want to get out of the time with us. And it's almost kind of like, turning away from that computer and not looking at that template that's in front of you, and actually then just finding what that patient wants. You can validate their story, you find out what's meaningful to them, and develop a bit of plan for the next time. I think you've done really, really well in that first session. And it also hopefully should take the pressure off you as well, because there's so many things we try to fit in a lot of the time, and I just don't think that's helpful.
That's it. People sometimes feel obliged to then hone in on a diagnosis or offer some sort of form of reassurance that can sometimes then lean on sort of more modern pain principles that can help. In the therapist's head, they think it's useful to say to the patient in the last couple of minutes that, this pain isn't representative of, say, the things that you thought it was. It's like it leaves them too disrupted. You've destabilized it. Say that had landed to some degree. You've not got the time to be able to replace it with a coherent narrative or something that they can make sense of. So it can be actually, you're better off not saying that and trusting then the service of which you're referring into. I think one of the things that's interesting is that Talita's point about communication across sectors in this instance, and we know that can even happen intra-sector, as you've mentioned, between primary and secondary care. If those things break down and we can't then trust each other to pick that up where you left off, then that can be frustrating. So we definitely have got some work to do there structurally. Thanks a lot, Dave, for a great point here. More cracks between the services, more patients can fall through them. Fantastic local clinicians in our pain management service, access and understanding of the access of the issues, and probably the time factor on appointments. I think that's the thing, is that we can all keep aspiring to this. And I think that the cross-pollination of staffing, I think, makes a big difference. I think that's one of the things we can try and learn from. If those distinctions happened less, and then you're going to naturally be able to upskill each other easier, because that staff base is interconnected more carefully. But yeah, lots to think about, and it's the sort of thing that you've got the clinical and educational level, as well as then the policy level that need to. That's not a distinction that needs to be really crisp either. These things need to inform each other, for us all to raise standards together. Thanks so much for exploring this with me today. If you just let the listeners know as to where they can find out a little bit more about you and how they can find more on the Wellness Puzzle project.
Yeah, so one thing I didn't mention earlier when we were talking about how I came to this wellness is, one thing I started to recognize when I was looking at kind of past medical histories from referrals and things like that is, we have so many patients who have more than one medical condition or on multiple medications and so on. And I actually started asking patients whether they had any guidance on improving their health apart from medications before in the past, and a lot of them said they hadn't. So yeah, I decided to set up the Wellness Puzzle YouTube channel. So yeah, it's the Wellness Puzzle on YouTube. You can also find me on Instagram, and also on Twitter at Mahin Kholi.
Brilliant, that's great. No, thanks so much for your time, mate. Really appreciate it. And I know that we've not managed to solve the entirety of it in half an hour, so I hope I can have you back in the future later in the year. And thank you all for participating. Please do leave your comments if you come into this, like most people do, after the fact, that didn't join us at lunchtime. Then you can just add your comments where they are, where you've happened to have found us, or email info@physio-matters.com, and that can inform future episodes. But for now, because we've not sorted out the outros and things like that, what me and Mahin are going to do is we're going to awkwardly wave until it cuts off. So bye.